Cuba gambar. Fatihah ni siapa Fatihah ni? Syuhab Abdus Aisyah. Kenapa tak ada gambar yang lain ni? Umi Fifah mana? Wan Ashraf. Siapa Wan Ashraf? Idham. Ada ke?
Ada, Doktor.
Aisyah Zulkarnain. Wan Umairah. Lambat diorang ni. Wan Ashraf. Mariah. Balkis. Normally. Sufyan. Okay, yang datang Wan Asar Razif, Azin, Maria, Nur Amani, Nurul Sufiana, Nabilah, Asma, Nurul Putri, Izian. You dengar tak?
Yes, doktor.
Boleh dengar tak?
Dengar doktor.
Boleh dengar
Ah,
doktor.
Nak start dah
Boleh, doktor.
Okay, Assalamualaikum. Dan ni lecture you pertama Pagi tadi ada lecture tak?
Ada?
Introduction.
Briefing.
Briefing.
Pagi tadi lecture apa?
Introduction. Briefing.
Okay, we go to history taking. Actually, there's no. You pernah ambil history tak? Pernah tak ambil history? Dia bertanya soalan, tanya macam mana, apa khabar, kalau orang tu ada masalah, bertanya what's happening. You ada buat benda macam tu?
Tak pernah lagi doktor.
Yes.
Only in PBL, doktor.
Dalam kehidupan harian tak buat?
Oh, ada. Ada.
Ada je tanya-tanya.
Nama busybody. Dia tahu apa busybody sangat pasal ni ya. What you're doing is in professional way. Professional way is part of your job as a doctor future. Then what you're doing now is you're training to ask the question, history taking. You know history tak? History to what is history? What happened in the past? That is history of all about. But what you are doing now, you are taking history in relation to the chief complaint. Something about patient chief complaint. That is, so you're not taking about history of everything or whatever. It is something related to patient chief complaint. That is the skill. This is the first skill that you have to have as a doctor. Patient can come to you, can talk so many things, and then what is your skill to ask what is the problem? What is the problem in the patient? Why they come to see you? That skill is an art, actually. It's an art of asking questions. You see, medical is not only science. What you learn in your preclinical is science. But when you come to clinical, you have to learn certain art. One of it is the art of history taking. See, what is clinical skill you are expected to have? One is ability to take the history, to understand history. Second, to do the physical examination. Third, to make a diagnosis and differential. Fourth, to plan for investigation. And fifth, to plan the management. This is all what is doctor all about. See what doctor all about. It's called clinical skill. And then the first, what are to be expected for you in the third year is ability to take history and to present the history, doing the physical examination, making diagnosis and planning the investigation. You're focusing on that. Management, roughly, you talk little bit is okay because you will learn more about it when you are in the final year, and then you're going to apply it, learn about it when you are houseman, and when you are become independent as a medical officer, you already know to manage. So at the third year, this is your focus point. Taking and present history, doing physical examination, making diagnosis, and planning for investigation. That is the things that you have to learn during the third year. You must know your basic knowledge of science, anatomy, physiology, biochemistry, pathology, microbiology, and pharmacy. All you learn in your clinical year, that 2 years. Your basis of knowledge, all science, anatomy, physiology, some things that have to, when you pass your exam, it's considered that you already have adequate knowledge to proceed to the clinical side, clinical. Then you come to clinical is where you apply the application of your knowledge and to understand, to know your patients. A different set already. We presume you have adequate knowledge already. But the thing you don't have is the art. The art and to apply it to the patients. Now you come to the real things. The things that the thing that make you as a doctor. The first thing doesn't make, the knowledge doesn't make you a doctor. Certain place give you a bachelor of science whatsoever, that certain we go, you reach certain knowledge, but you are not a doctor yet, because now you have to apply what do you know, what do you understand, in your patient. Because if you don't have preclinical knowledge, you will become just like another layman person. Nothing. You're another person. Dia jadi tanya soalan pun, you bertanya soalan pada pesakit, soalan biasa lah, macam orang lain tanya soalan apa, masalah, sakit apa, ni semua setakat itu saja. You cannot think what's behind it. The basic knowledge, the base knowledge is the one that make you think what behind the problems that when the patient come to see you. You must able to connect between the preclinical, clinical. If you're unable to connect, it's a waste lah what you learn for the first 2 years. Teruk belajar first 2 years kan, hafal tu, hafal ni, banyak mudah hafal, betul tak? Ni semua ni tak kerja lain, hafal je, betul tak? Hafal. Tak kerja lain, sampai pun exam pun hafal semua kan. But that's the purpose for that. There is purpose. The purpose is for your application during your clinical year. It just not, the subject was chosen for this. Tapi kalau you are belajar pass exam, lepas tu you thought that pass exam finish, I don't need to learn, then you are not, you don't understand why you learn. Why you learn all these things at preclinical. Sadly lah, I think you belajar you lupa. Sayang ni, teruk belajar tu lupa. So in history taking, there are 3 things you must be able to understand. Just not history taking. Not only ability to extract the history, you must also have the ability to critically evaluate the history. When you get history, they still come to you in many ways. Some will be smooth, clear. The other one is so unclear, vague. The other sometimes is what is it? You're not sure. They chancha marba and so on. But you, when you extract the history, now after that you must able to think the history critically, evaluate history. And last thing is something that many of you weak is ability to present and communicate the history that you know to other people if you want to discuss or you want to present. That is something that sometimes inside your brain, banyak benda, it's a lot of things, but you're unable to communicate it. You see, for us, we only know, we can assess you from whatever come out from your mouth. Kalau 10 words lah we assess you. 10 sentence. If the thing come out from your mouth is quality, we think you are quality person. If the info that come out from your mouth is not quality, rubbish, we think you are rubbish. You cannot blame us, because we cannot see what inside your brain. If I have a meter, open up your brain to test whatever inside your brain, I know whatever inside your brain is easy, but there's no such thing. So whatever come out to your mouth, define who you are. Remember that. And the communication is an art. How you use the proper words, how you economize the words, how you want to give proper informations, how you want to make people understand what do you understand. It's the art. Some people, they have that capability, they were trained earlier in their child life when they are small, they like to present and so on, like to talk. As a result, they have quite easy when they want to present something. Some people are not that easy. So it depends person to person. But at the end of the day, the key thing is practice. If you're not good, then you practice. You practice to make you a good presenter, good communicator. The more the practice, the better you are. So remember, history got three things: ability to extract the history, ability to evaluate the history, then ability to present and communicate the things that you know. So we're talking about history. You in children's, you know that 2 years old, 1 year old child, they won't able to communicate with you. If you're talking about adult, yes, they can talk to you unless the patient got stroke and able to give you history. Or many adult, even adolescent and the older children can give you info. But in pediatrics, many patients, even majority of the patients, usually unable to give you proper info. So you will try to get the info from many sources and as much as possible to help you, because sometimes from one sources, sometimes it can be adequate, it can be not adequate. Sometimes you collect from the father one day, then you found out you're not clear what's happening. You have to wait for the mother to come to collect the mother. It seems like caregiver, and sometimes even some patients, older patients, can give better what's happening to them better than their parents. So you have to be very careful. It's the art, the skill you have to understand. The thought that you take one history from the one source, you say, oh, you think it's adequate already. Sometimes you'll be surprised that the other people, those can give you a bit different history, a better one, from the what you get from the first source. So history in children is tricky. So the source of history is very important for the mother, caregiver, patient, father, and sibling. Sometimes if we have time, we club both parents, mother and father, because sometimes the combination of their info of history from the parents will give more information rather than the history from one person. You have to have inside you this dissatisfaction of to decide the history is adequate, not adequate. Don't take things from the horse of the mouth just like that. You must realize that. And the principle of taking history is that inside your mind, you are an investigator. No? You are an investigator. Your brain set investigator. Don't bother people say you're busybody ke whatsoever, doesn't matter. No. But your job is to get the info. So the principle is that inside your mind, you should have this concept of when, why, where, what, who, which, how. You have to have the concept inside your brain. If you don't have that concept in your brain, it's going to be difficult. You won't be able to get a clear history and a logical history. You have to build inside you the concept of when, why, where, what, who, which inside your brain. Always ask the question: when is, why, where, what is it, who is it, who do it, who with it, and which part, how it happened. You have to be that kind of concept inside your brain. Even in all history you take in any patients, you have to have that kind of concept inside your brain. If you don't have, then be sad lah. You will be just asking macam question, tanya soalan apa tu, narrative only. You have to be an investigator. And the other concept you must have is that chronology order. Event after what happened next, what happened next, what happened next, what happened next. Which one come first, which one come later, which one come rightly before emissions. The chronology order of things. So your brain must have that kind of thinking, step or step, chronological. Don't go today, suddenly you go 2 days ago. Then you go 4 days ago. It doesn't it get you confused. You have to go start when the problem started. 5 days ago, went down 4 days, 3 days, 2 days, 1, and your brain had to work like that. 5, 4, 3 days. Start pin down from the first thing, first when it occurred, first date, and then went down. And then the end point for you all is when the patient came to see you or patient been admitted to the ward. This is your endpoint. 1 day before admission, 2 days before admission, the endpoint, the chronological order. And then if you have that concept, then you can have clear and logical history. If you're not getting that, please ask question. Please ask more questions until you get clear and logical history. If you see blur everything, you cannot make up, ask the question again. The history has to be clear and logical. You're crystal clear what's happening to your patient. So history started with chief complaint. They are always, this one you use always. There are always a reason why there is a why the patient come to see a doctor, or the parent bring the child to see the doctor. There always a reason. If there's no reason, something's not right with the situation, with the parents, with the baby, something's not right. But there always a reason why people come to see you or bring the child to hospital. That's about saja-saja. Mesti ada reason. Then it's your job to find out what the reason is. And then that is the chief complaints, will be the chief complaints or complaints. Actually, by right, chief complaint is one only. Many times it's just one complaint or main complaint why the patient was bring, or why the patient came to the hospital to see you. But sometimes you can have a few complaints. You see, I always like ask fever for 3 days. Fever come to see you for fever 3 days. But then in GP setup, probably it's acceptable. But in our setup, fever alone, usually, that's why I ask you, fever for 1 day alone, there are many people, there are many people with fever not been admitted. So why they bring child with fever to hospital and been admitted? Surely something else other than that parent bring. So you have to look around, you have to look to understand why. If patient come to see GP, yes, fever, then fever for 3 days, that will be the chief complaint. Fever come, but then the reason they came to the hospital because they got fitting. So the chief complaint will be fit, not fever, fit for 3 days. That's why the reason to be into the hospital. So you have to find out what's the main reason. The main reason why the patients came to see you or bring the child to bring you. If you are unable to find out that, it means you have not passed the first test, the first level. Something is not right with you, not with the patient. You are able to find out what is the chief complaints. You are able to identify, it means something wrong with you. It's not with the patient. Something not right. Why the patient was brought to the hospital, came to see you. I said, if you see a doctor, you have to find out what is it. Because important to understand the chief complaint, because the whole story of history, even clinical, depend on the chief complaint. Because it set the pathway to you how to ask, what to ask, which thing to ask, because there are 1001 issue. So you have to know what is the main issue, why they bring, what is the issue that they came to see you. Very important. That the first thing first you must able to identify. If you're not unable to identify, then you have to ask, keep asking question until you're able to identify, or you ask somebody else to help you to identify it. And then most of the time, the chief complaint consists of symptoms. Fever, feet, shortness of breath, and then cyanosis, jaundice, all these set of symptoms. Set of symptoms. Sometimes sign like jaundice, but yeah, signs. And then the set of so that is the reason the most of the time the chief complaint consists of that. So you know what symptom is, what sign is? You know what symptom and sign is?
Yes.
Yes.
Very important. You are unable to know symptom and sign, is difficult to go forward. How to differentiate symptom and signs, and sometimes there can be overlapping. History consists mainly symptoms. After that, you go to history of presenting illness or present illness. The many HOPI, presenting illness or present illness. The key here, the presenting illness or present illness. Illness, that the illness defined is any unwell. Why the child is unwell? There is history of that. And then as we go before that, previously it consists of when this fever, the example fever, when the fever was started, question when, then history that you see you think why it started, where the origin of the fever, what is the fever characteristic, or so this how the you ask the questions about the illness. If the child come in, let's say shortness of breath, so it come automatically to you when the shortness of breath come from, why the child having shortness of breath, what is it, how is it happen, all things come to you when you ask those questions. And then when you goes by, as I said earlier, you have to go try to go according to chronological. It's occurred 3 days ago. That's 3 days before admission. 2 days before admission, the shortness of breath become most obvious, right? More tachypneic. And then the shortness of breath on the 4th day, on the day before admission, the child start to be cyanosis, and those which was admitted on that day because of the shortness of breath and become cyanosis. You see chronological order. So fever for 4 days. The first day having URTI, then the second 3 days before admission having URTI, 2 days before admission URTI with fever. On the day of admission, child developed fit. So these are chronological order. You don't go, if you don't, you try to get the history according to the chronological order, nice like that. Then you can present nicely. And you have to decide, is it acute or chronic? The illness is acute or chronic? It's occurred 1 month ago, persisted until now, chronic. It occurred 1 day, 2 days ago, fit was 3 days ago, but then it was first episode, so it's going to be acute. You are very clear of that. Let's say patient is epilepsy. They got breakthrough seizure. The event is acute, but the disease is chronic or acute? It is chronic, because it's epilepsy. Let's say the child is having febrile fit. First episode, febrile fit. It is an acute illness. So very important to know the disease you are dealing is, the illness you're dealing is acute or chronic. And then severity. Your history also might consist able to the people who listen, and when you after you clerking the case, you must be able to make a conclusion. How severe is it? Is it a mild, moderate, or severe? Let's say the child having with shortness of breath, but noted only just tachypnea and cough, nothing else. You know it's a mild. Let's say the child has got shortness of breath, but at the same time, patient noted there is intercostal recession, subcostal recession, and the child's decrease in feeding may be moderate. Or the child having shortness of breath, patient come to say shortness of breath, but noted to be cyanosis and drowsy. You know it's a severe. So your history have to be, you in any illness, when you finish clerking, you must able to conclude your patient is mild, moderate, or severe. And last thing is that please remember positive history and negative history are equally important. Let's say patient with shortness of breath. At the same time, patient got subcostal or intercostal recession. But negative history, patient have no cyanosis. So it tell you that severity of the patient is not probably moderate terms. So it tell you. So the importance of negative history is there, no cyanosis. If you don't mention that, if you didn't ask that, then we consider you don't know. So like fever or fever is temperature is high, and then but patient still can tolerate overly. Patient has no vomiting, then you know patient have fever, no got chills, but no rigor. Rigor is negative history. So it tell you, it help you to make to point out few things. Chills without rigors. So those things are very important. So positive history and negative history are equally important. Why? Because I found out many students why they mainly present the positive history only. The thing is systemic review, very complicated. I mean that system to system. You systemic review system to system. You won't realize the two things about systemic review. If us doing history taking, usually if you don't have much experience, you ask because you want to. Sometimes you go through system by system to look the things that related to the chief complaint. Chief complaint. Then, or sometimes you want to look things that you don't want to miss, not related with the chief complaint. The two things, remember that. You just ask, ada cough, ada knee, ada two. But some of the things related to chief complaint or HOPI, some of the things doesn't related with chief complaint. So you have to decide. The systemic review all about. We discuss how to present later. And then we go for the other history to complete the physical examination. Other history. What are the other history? To complete your history taking, other history. What other history? Past medical history. Past medical history is any other history that patients has but not related to HOPI that patient recover or still ongoing. Let's say patient coming with shortness of breath, but previously last time he's having appendectomy. That is past medical history. Let's say the child is having abdominal pain, but at the same time it was treated as eczema. So you know eczema, although it's ongoing, but not related with the abdominal pain. So it's still considered as past medical history. You must really understand that past medical history. And then birth history, excluding the antenatal history. Certain case birth history has to be basically birth history lah, lahir, macam mana, cukup bulan, lahir, lepas tu cesarean atau lahir, lepas tu SVD, spontaneous vaginal delivery, or instrumental lahir, postnatally lahir, berapa lama, jaundice atau tidak, all those things lah, that is basic thing. But sometimes in certain case, like the case with fitting at the age of 4 months or 3 months, your birth history has to be complete. The entire history has to be complete. The mom having fever or not during the antenatal, ada problem or not, the delivery child, the food is delivery is any problem or not, on the child cry rightly after delivery, what is the birth weight, or those things are content very detailed, depend on the case chief complaint, chief complaints. So of feeding and dietary history, at certain time it has to be very detailed. Feeding, breastfeeding, then the child after that weaning at the age of 6 months, and age of 1 year, introduce food at age 1 year, introduce eating the oral as like adult feed, adult diet. There is a basic things. But at certain times, let's say patient having failure to thrive, or patient having obese, or patient having patient obese, or patient like certain patient have evidence of vitamin C deficiency. Those things, the history had to be complete. The dietary history has to be very detailed, very complete. Even what is the breakfast, what's the lunch, what is the afternoon break, and what is the dinner. Very complete to know. Let's say patient with obesity. So because the patient with obesity, dietary history is a key in managing this patient. You have to give detailed history because it helps us to find out the cause of obesity. So you have to see case by case. Very important of that. Immunization history. Immunization history, what the first thing you must know before you ask immunization history? Anybody?
Is the baby was vaccinated?
Anybody? Macam mana nak try? Wahimi, what the thing you should know? You think very important thing that you were talking about immunization history.
The age of the child.
Okay, the age of the child. Anything else?
The immunization table.
Yes, that's the thing. The most important thing is you must know the immunization schedule in this country. How you want to ask how you want to make a conclusion about immunization of the child if you are unable to, you don't know the immunization schedule in this country. So you can, because you have to make conclusion. If the immunization is adequate according to the age, or there is some delay in immunization, because that's doctor all about. Because the conclusion very important. After you certain case, like say patient come with pertussis, or patient come with diphtheria, then we would like to know if they been adequately immunized or not. So it's the principle of before you ask the question, or before you clerk the patient, is to know the immunization history, and then you have to see the patient age and compare it. Is it adequate or according to the age, or delayed? The conclusion has to be there. If not, no, what's the point you taking the immunization history? The other thing is developmental history. You don't have this in adult, definitely. But So as in immunization history, if you want to ask questions, you have to has the basic knowledge of the thing you want to ask. Example, in developmental history, you must know the developmental parameter or milestone. What is normal? Let's say you're talking, you must, let's say, what is the normal age the child able to sit? What is normal age the child able to turn over fully, able to sit, able to stand, able to cruising, able to walk, able to jump and run. You have no choice. You have to memorize this. You must know the parameter, the milestones. And then when you ask history of developmental, there are two things you must realize. One, you want to know the progress of the milestone. Is it normal or not? You may see the child of age of 6 years, but when you ask the milestone, you found out that they walk at the age of 4 years. So you know that though most of them walk at the age of 1 year and run at age 2 years, usually you don't let them to give some to give them some, let them so far delay. No, 18 months, or perhaps you can look at it, male or female. But if they walk at age 4 years, when they come to see you, they seem able to run, but they still have history of delay in walking. So the progress of the milestone is also important. Not only because many of you, when you present, most of the time you present the developmental is what the patient currently can able to do. When the patient would, oh, my patient now can run, can talk, can knee, so, but we found out the patient got some delay in some, in overall in the history. When you see the progress, because something is there we are missing. So two things must remember: the progress of the milestone. The second thing, what the currently the child or the patient can do. It's just not only what the currently patient child can do. And then usually sometimes we make, to make the life easy, we ask them to compare with the other children. Usually mom can compare, can tell you, oh, like the other children delayed or faster. Mom can tell you, it's a guide, but not definite. Because if all the parents are, all the children is delayed, then it can misguide you. Or like the other children, you don't know that the other children also delayed. So you have to look, it's a guide. To guide, to compare to the other children or other siblings. To help you, to give you some guide that is the child having a obvious delay or not. So we're talking about developmental history. Usually, mainly the four things you ask to go through: the gross motor, the fine motor, and vision. Why you put vision and fine motor together? Because without vision, you cannot develop the fine motor. Language and speech. Because if you don't have language, you are unable to. You don't have. If you don't have the speech ability, you cannot develop language. So they got some, they combine together. And social, and then at the older children, we do ask you to roughly give us the cognitive level of the patient, roughly. But the first four is the main things. We will discuss this further in other session. Family history, very important also in pediatrics. You must be able to construct the family tree. You tahu family tree tak? Cabang-cabang tu kan? Ni semua yang betul construct. Dia pernah belajar macam mana construct family tree? Tahu tak? Tak tahu?
Tahu.
Family tree.
Tahu.
Then we ask for very important history, consanguineous. Tahu consanguineous?
Yes.
What consanguineous means?
You marry your cousins, for example.
Anybody here is product of consanguineous? Anybody of you? Any one of you, sir? Any one of you product of consanguineous? Tak ada? Semua non-consanguineous. Consanguineous cousin, two cousin, first cousin, second cousin. Okay, second cousin and below. Means second cousin, first cousin, they're consanguineous. For the same ancestor, that's consanguineous. Definition consanguineous. Second cousin and below. It's just that because the gene is not spread widely enough. That doesn't mean that they are abnormal. To realize that, but the chances of being abnormal is there, higher than non-consanguineous. That's all. Is it wrong to marry your cousin? To marry your cousin? Wrong, not wrong. You think what you think? Is it wrong to marry your cousin?
No.
Suddenly you fall in love to your cousin. It can happen what? Tak pernah berlaku ke? You think tak pernah berlaku ke?
Legally not wrong, but medically not.
Besar, tiba you fall in love to your cousin. Dan cerita dalam Melayu tak berlaku ke? It can happen, kan? So, it's not wrong, but it's just that the probability of having the if you have the abnormal gene, it doesn't spread wide enough to give lessen the chance of having abnormal child. But sometimes there are people who are first cousin, anak keluar lebih intelligent daripada those who married daripada jauh-jauh kan. So they all got probability. The other thing you must understand is that the genetic disease, the pattern of inherited. So in pediatric, many genetic disease, you can when you ask the history, you can roughly estimate the pattern of inheritance. You tahu autosomal dominance, X-linked, semua tahu kan? There is pattern of inherited. And sometimes dipanggil single gene, multifactorial, all those things. So you can roughly think about how to construct the family tree and then to understand the inherited of the abnormal gene. Any question now? So the other history, drug history, what's taken, any medication taken, the asthma, they take the MDI or asthmatic medication, the hypertension, the asthmatic hypertension, the asthma medication. Look for social economic history also, daily activity, school, pattern they are at school, how are they able to go to school or not? Can they go to school or not? What is effect, the disease affect their school performance, and their daily activity or ability to play, exercise, all those things. You have to ask in the history. Environmental, you have to know, especially those certain disease, example like asthma. You wonder why the child asthmatic poorly controlled, continues having asthmatic symptoms. Then you found out that this father are smoker. You found out that they are living near to the factory. You see, example as the patient develop acute gastroenteritis. Why the patient develop acute gastroenteritis? It just, patient develop diarrhea. It's just not that only. You have to find out the environmental factor. You tengok rumah dia tak ada air pipe. Dia pakai air sungai saja, air perigi. So all those things are needed because it is part of your management. Oh, Akmal Hashim Syam sampai terngantuk-ngantuk kepala turun. Akmal, pusing kepala ya. Okay. This is history. Any question until here? Are you clear or not?
Clear, Doctor.
Clear, Doctor.
Clear. That is the history taking. Senang susah? Banyak sangat?
So far so good, insyaAllah.
So far so good.
Kita cuba.
Okay, after you took the history, you know the history is, you write summary, some people they make notes. I very fascinated those who taking history but didn't take notes, especially the new one. Memang wah, kata kagum lah because I dulu macam mana memorize all those things. At my level, probably I don't need so much because usually I know what to ask, unless it's very complex. And then, but after you return, you taking the history, you sit down, you look at the history. Jangan terus present. Nak present ke nak duduk dulu. Look at the history. Look in terms, as I said to us now, the concept of Y, W, the concept of chronological. Look at the case, chronological. The concept of the severity. Look at those things. Do that one first. Look, sit down. And then you have to able to critically think about the history. Identify what's the problem is, where the problem is, when it happened, which process involved. Is it infection? If it is inflammatory, is it tumor? Is it endocrine, or is it any other things? Which system involved mainly? Is it the respiratory? Is it the GIT? Is it the CNS? Or any other system affected? Maybe the respiratory the affected main system, but probably the CNS is also affected. Is it acute or chronic? Look, is it how severe is it? Is it mild or moderate or severe? And look for the complications. What is the complication of the illness? You see all this at the background of your anatomy, your physiology, your pathology, your physiology, your biochemistry, and your microbiology. All this, you have to sit down and think about the history you've taken. Every cases, you thought it's simple one, just a febrile fit, but then sometimes the problem is that you are biased, mainly because you read a case note or whatsoever, but you don't know probably something else. Have you excluded something else? You have to train your mind on that. Then, believe me, you become a safer doctor. Many of you just taking history and present, that's all. You're not doing the critical thinking about the history you've taken. If you think it's not complete, what you should do?
Ask more question.
You go back and ask the questions until you complete. You must have the sense of perfection about the history. You say, oh, not complete, something is not right. You go back and ask. That's how you do. You go back and ask. But please practice the preclinical science, the anatomy, the pathology, the physiology, biochemistry, microbiology. You practice on that. That's when you think according to the as a scientific person. You see, when you ask question is an art, and then your basic is science. How you extract the questions, how you clerk, everything is the art of clerking. The art of clerking, you call the art. It's just like any lawyer ask question pada dia punya klien dia atau dia punya cross examination, semua lawyer macam tu kan. It's the art. But the difference is that you have science underlying it, because you're talking about medical science. Medical is science. So the science underlying it, you have to combine those things. Then last thing is that after you have those history, you analyze it, then you have to present it. And then this is another problem, especially for Malay lah. Another problem. Another problem to present in terms to present with clarity, to present with logic, common sense, to present with clearly, logically. There's something that is another art of communications, to present the history. Usually, we started by introducing the patients, siapa patient you, and then source of history. You have to tell us the source of history, where you get for a parent, for a child, for a mother, for a parent, tell us. And you have to tell after that the chief complaints. In chief complaints, it is adequate just to tell the chief complaint and the duration. Fever for 4 days, fit for 3 days, 1 episode of fitting, or generalized tonic-clonic fitting, fit for 1 day. Just all. No need to characterize the symptoms. Just give the duration only. You give the chief complaint only. Fit for 3 days. That's all. Then when you give the history of present illness, you have to present anything related to the chief complaint. Even when you do systemic review also, but if there's anything you found out during your systemic review related to the chief complaint or HOPI, you present to the HOPI. And during this time, you characterize the symptoms. Each symptoms present. Fitting for 3 minutes. And then the child pre-fitting, we got some lightning, feel the stomach ache. Then child start to have a generalized tonic-clonic feeding. Feed both the upper limb rolling tone movements, and then occur in 2 minutes. The child also lost conscious. They're drooling with saliva, but no incontinence. You have to characterize it during that time. What happened during that time? You will characterize. You don't need to do in the chief complaint, but during the disease, any symptom that patient present, you have to characterize it. As usual, when, why, what, and where. And then in chronological order, as we discussed earlier, what happened 3 days started with URTI 2 days ago, and then on the day of admission, temperature become high, and suddenly the child having 1 episode of fit, characterized by so on like that. Post fit, the child is look conscious, fairly good conscious, but the parent still bring the child to NE and was admitted to the ward for observation. That's all. And then the severity of the disease, how severe is that? And then the complication, let's say about let's say the child is having acute glomerulonephritis, then hypertension, and the hypertension, as a result of hypertension, the child develop fit. It's a complication of the AGN, glomerulonephritis. So the fit itself, you have to mention part of complication. You have to tell us there is the complications, just not the disease illness itself. And then, as I said to you, positive history and negative history are very important. Let's say patient is having AGN, hypertension, but no fit. You can see patient having hypertensive headache, patient noted to be having headache, vomiting, but there is no fit. Important to us, important to you all also, for the doctors to understand that the child having the sign and symptom of hypertension, but there is no severe one like fitting. So the fitting will be negative history, the vomiting and headache will be the positive history, and it's equally important, very important that. And if you want to mention systemic review, it should not be part of HOPI. Let's say the patient, you have clocked the patient with shortness of breath, and the mother says, so, oh, there is a rash at the buttock there. Then noted that patient having rash at the buttock for the past 2 days, probably, but then it's not related to the chief complaint, is it? The chief complaint is the shortness of breath. Because anything related to the shortness of breath will be in the HOPI. Because sometimes the patient, somebody present shortness of breath, shortness of breath. But in HOPI, in systemic, you present suddenly, habis present HOPI, systemic review, patient also have poor appetite, didn't take orally during that time, or also patient have been vomiting. You know, this can be related to the shortness of breath. Why you want to put in systemic review? Put inside the HOPI. No need to put inside the systemic review, and no need to whatever you have informed in system HOPI, you don't need anymore to repeat it again in the systemic review. Don't need to repeat. System review for something else that probably not related to HOPI and you don't want to miss. And then after that, you present the other history that we discussed earlier. And then later on, after we ask, then you go what progress in the ward. HOPI progress in the ward usually not. If you clerk as you are, when you come as a student, you progress in the ward is another set of story. Your end point is admission to the ward. Then progress to the ward is different story, because it's already intervention in the management. Don't put progress in the ward in the HOPI. If you clerk your case lah, it's what you are, because when the training for you all is to be a houseman, and to be a house thing, and the houseman is until the patient be admitted. Because when you see your patient as houseman, you see you're going to clerk your case when the patient admitted to the ward. So this is just like a simulation. Okay, any questions? To remind you again, there's no magic bullet. There's no magic bullet. When you listen to me talk, if you have not yet clerked your patient, definitely there will be some blur. You're blur, going to be blur. I can show you don't want to be blur. You're going to blur. But when you start clerking your patients, when you start thinking about your patients, when you start to want to present your patients, and then you understand the intricate, how intricate it is, very intricate. You understand how to apply what you have listened and how to apply it to your patient. The first one and second one usually is difficult to adapt because you're still in the process of learning. After third, fourth, then you found it easier. The fifth and sixth start to become routine. So the key is what? The key is to practice. There's no magic bullet. The more you clerk, the better you're going to be. Believe me. No way you can clerk 1 or 2 cases going to become good. No way. You have to clerk many cases. The more you clerk, the better you're going to be. There's no magic bullet. Dia tak ada pil makan terus boleh jadi pandai. Atau pil you makan terus you boleh clerk patient. Tak ada. You have to go through the process that what we all have been gone through. That's how we all gone through the process. Keep on practicing. Even now, I still practicing. Sometimes I still not very clear about the history. I still sit down and think about the history and clerk again and again and again. It's going to be part of your life. Unless you become administrator. Part of your life. Definitely. Not much choice you can have. Because you already decided to become doctor. Is it? You already decided to become a doctor or not? Have not decided. Masih lagi testing. To become doctor, not to become doctor. Testing lagi ke atau dah memang definite nak become doktor ni? Oh,
InsyaAllah.
minum. Apa tak minum lagi? Minum botol tu, macam tu. You memang jadi doktor ke? Then, you know, this is your tools, Al-Hakim mana? Al-Hakim mana? Muka mana? Hakim? Gambar-gambar tu. You have no choice, Siapa tadi? Wan Ashraf ada tak?
Ada doktor. Ada.
Ada. Mariah?
Ada doktor.
Nur Amani?
Ada doktor.
Nurul Sufiana?
Ada doktor.
Nabilah? Nabilah ada? Tak ada, Asma?
Ada doktor.
Nurul Putri ke Nurul apa? Nurul.
Ada doktor.
Ya, Isyan Fatihah.
Ada doktor.
Nabilah tak ada.
Doktor, Nabila tu Nur Nabila ke Hanun Nabila?
Kau tahu Nabilah Safril?
Tak, saya Hanun. Nabila Safril.
Nabila Safir, mic dia rosak. Nabila Safir ada tapi mic dia rosak. So dia tak boleh nak jawab.
Muka dia.
Tak
boleh nampak muka dia.
Ada, kalau dia ada dua account. Ada satu yang tak nampak muka, ada satu yang ada.
Macam-macam dia orang ni. Tak dapat akaun ni 10 orang. Satu akaun ni dia. Ada apa nak tanya? Tak ada apa nak tanya? Tahu semua benda lah.
I have a question. For system review, what is we go by system, right? So for physical examination, we also go by the system.
Physical examination?
So what is the difference?
System review, you mainly ask the symptom, ada cough, batuk, ada shortness of breath, ada ear discharge, mainly ask symptoms. Human history is mainly symptoms. Kalau physical examination, dia tengoklah ada tinga, ada air tak, ada nanah, tekak, ada merah tak, throat injected or not. That is the sign. That's the difference. Physical review, you just ask system review, ask question. But system review ni, you don't miss up. System review ni, you know, satu, don't waste time on that if in the exam. Second, you know, it's just to make sure you don't miss anything. And third, if anything related to chief complaint, it still goes into your HOPI. It's not stand on its own. You want to talking about shortness of breath. So the system review, it will mention patient cough. Of course, why is it you want to put cough in system review presentation, whereas you know the chief complaint is shortness of breath. You know, cough and shortness of breath are very related. Why not you put the cough should be in HOPI, not in the system review during presentation. You present, don't mix up what you present, what you ask. Okay, you ask those things is to make sure you're complete asking the questions. But at certain level, when you are already certain level, you don't need to ask. You know that you don't need to go system review because you already asked most of the things that you want to know. Okay, any other questions? Tak ada. Tak ada, finish lah. Berapa jam? 1 jam. Cukup 1 jam. You all ni tengok tadi berpusing-pusing, berputar-putar macam-macam tadi. Inilah semua berputar-putar, berni semua. Mesti ada mengantuk lah, ada ni ya. Bila you balik semula sini?
9 November.
Bila?
9 November.
9 November. Masa tu you punya sini dah habis exam dah. Boleh lah. Tidak ramai sangat nanti. Okey. Habis kan?
I have a last question. I have a last question.
You have a last question. Jangan main tu. Okay, apa?
Okay, so for history, you mentioned about asking the mother caregiver. Can we actually look at the macam database for like a more accurate history macam?
History is what you ask from the parents, or for people. History. Your database. Sometimes the parent do bring a book, no, by his side, and then that is acceptable. The book, sometimes they bring a book from the mana-mana ni. Kadang-kadang buku, kalau ada kidney problem, lepas tu dia bawa satu set buku, all the urine test, everything semua. Yes, that's another one. It can be accept a part of the history, punya source of history, part of source history. Okay, but in real life, you can get history from any source you think is necessary to construct the patient, to understand the patient problem. In real life, construct the patient problem. Sometimes with the old notes and so on. That is real life lah. But for your level of learning is for you clerking the case, and then from the patient information book kalau ada, kalau dia bawa bersama lah. Okay. Any other questions?
Doctor, for the patients that we've clocked, so do we have to follow up with the progression in the ward as well?
Good. If you can do that, it tells us that you have interest to the patient, but you have to separate the history, HOPI, and the progress in the ward. Don't mix it up. Okay. Don't mix it up, because the progress in the ward is intervention has been done already. It's done already, so you don't get the pure history anymore. But it's good to know. And then if we ask you what's happened to the patient in the ward, then you can tell us what happened to the patient in the ward. So we know that you keep tight on the patient. You're interested to the patient. But during your presentation, you just tell us until the day of admission. Okay. That is a pure history. After that is intervention. But it's okay, it's good if you can keep track on the patient. It tells us that you are interested with the patient. Okay. Anything else?
Thank you, doctor.
Okay.
How do we know what a positive or negative history to ask the patient?
How you want to know? Basically, it's what related to chief complaint. Let's say the shortness of breath. There's many things related to shortness of breath. It can be related with the tachypnea, can be related to chief subconstant social recession, cyanosis, wheezing, stridor. So those related with the chief complaint. What is chief complaint? So those who are there is positive. Those is not there will be negative. Let's say example, shortness of breath. The chest have been wheezing, having stridor but no wheezing. So stridor will be the positive, wheezing will be the negative. So still equally important. It tells us what the possible causes, the negative history and positive history. But when you're clocking more and more symptoms, more and more cases, you recognize more and more symptoms, you can figure out which one is which is the positive history, which is negative history. You will figure out. Okay, anything else? Okay, you dah finish, we close the session. Okay. Tak ada apa Aku dah keluar lagi ya.
Thank you, Doctor.
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 Thank you, Doctor.